So if you will, just take we'll be taking just a couple of questions for the doctor from the ATI consensus meeting.
Okay, just before the questions come in, I just like to say that I have a lot of colleagues who are at the workshop as well as in the planning committee in the room. So hopefully they'll also help me address some of the questions I'm sure that are coming.
So thank you for the presentation, and lots of it was very interesting. But from my perspective as an advocate, I'm concerned about safety of participants in studies, and I feel like I'm saying the same thing again this year. I've said last year at other meetings. It isn't ethical and it isn't safe to withdraw the CD4 Nadia criteria just because some potential participants don't have a CD4 Nadia. And one of the things that you said is that we do not have data about what happens with a...
If you could project your voice from the microphone.
Yeah.
Yeah.
So one of the issues about CD4 Nadia, which all of the advocates worked really hard to include in ATI studies when they were first being projected. So 20 years ago, we were worried and concerned that you interrupt treatment, you're going to have a higher risk of bad things happening. And that definitely happens. And the lower your CD4 count is, the higher the risk that bad things will happen. We have this data. We've had it for 20 years. We've had it for 25 years. You have a low CD4 Nadia, your viral load will rebound quickly. It will rebound higher. Your CD4 count will drop more quickly. It will drop lower more quickly. And it will take longer to recover. So somebody with a low CD4 Nadia, the CD4 count will drop down, that's clinically important. It will take longer to recover, that's clinically important. They will be at risk for longer. That's the data we have. And you said with respect that we don't have the data. It's just not good enough. It's a tiny little line in your projected new guidelines. But I'm not the only person amongst community advocates who are incredibly upset at the prospect of this being withdrawn, just because you want to run phase 2 studies, cure-related studies in different countries. Moses is here, who when I first met him 10 years ago, was probably more prescient than anyone in the room, when he said, of course we need cure in other countries, including African countries, because I do not want to worry about who the next US president is. Well, he said that 10 years ago. We're at the point now where US funding has been withdrawn, and you can't run these studies in countries where you can't guarantee access to medicines afterwards. US has funded prevention studies and PrEP studies, and now we can't guarantee access to those compounds and those drugs in these countries. This isn't the time to be trying to push the boundaries of HIV cure-related research where there's a safety issue for the participants.
So just in time, we are going to have a moderated discussion about the pros and cons of ATI. We do have folks that are going to be talking from the con side as well. At this point, we do want, if anyone had additional questions about the presentation we have at hand, we have 2 more presentations, and then we're going to be going into the moderation.
Thank you. So my question was there any consideration to post-ATI follow-up of the participants, since the reservoirs could be depleted and then reseeded rather, and what are the consequences in terms of inflammation-mediated complications and that sort of thing? But I think long-term follow-up is a real concern.
Yeah.
And it didn't see that in the recommendations.
And I apologize, I didn't put it up there. I didn't.
If I could,
The question was about long-term follow-up of people who have been in ATIs and safety concerns for those people. And was there any discussion? And yes, there was a lot of discussion in the meeting about long-term follow-up of individuals who are in ATIs to assess issues around clinical safety, long-term safety of ATIs, but also to look at issues like the reservoir and how is that impacted when participants have been on ATI. And there was a specific recommendation that there should be protocols independent of the studies themselves that should be developed for long-term follow-up of individuals who have been on ATIs.
any other questions? Remember, please project more.
Just two things. And you said the kind of in your whole thing there, it said, well, depending on this and depending on that, that kind of is very dubious open. But one thing is, I don't think that there should be an ATI and that there should be a placebo group in the pilot study, a small pilot study. Shouldn't be there. But it's just should. Yes, when we see, if you see something, you're going to need to do a larger trial. You're going to have some kind of a placebo arm. And the second thing is, people who, whether you're HIV positive or not, when we get older, our immune systems wane. And so it would be unfortunate if you allowed older people to be in a trial when it's a smaller study, just to see if you've got something there, and have it all messed up and then say, oh, we don't see anything because of these older people who already have a waning immune system.
I completely agree, and I think the key comment there was about that they should, for placebo studies to happen, they need to be powered properly statistically, so that you are actually answering a question that is really important, statistically powered before you introduce a placebo. And I also agree about the age. There was a lot of discussion on this, but it was mainly going to be product driven. So there might be certain products that the investigators believe might not have the same efficacy in older people. And these recommendations keep the for the decisions to be made not to include older people. So every study is going to be different. So these recommendations are not going to be universally applicable to all products. There might be products where you decide, the investigators and the study, in consultation with the community, decide, no, this particular product is not appropriate for people of a certain age. And that should be a study specific.
Thank you so much, Dr. Tundi. Question on the composition of the steering committee and the people who participated in Nairobi. I had a question that did we have some of the participants coming from the team of 2019 join you this time round, or this composition was typically for new, especially clinicians?
We had a lot of participants, including in the organizing committee of people from the 2019 team. The 2019 team was led by Boris Yu. He was part of the planning committee. There were other people like Steve Hicks, and many others that were part of the committee that I'm not going to mention. But yes, the idea was to incorporate some of the people from the 2019 committee, but also bring in some new faces. And because I'm sitting down, let me just address the question about the NIDA CD4 count. I think we can have further discussions during the Q&A as was mentioned, but I think the overwhelming feeling was that there is not evidence, scientific evidence, that the NIDA CD4 count affects the outcome clinical in an ATI study. There is evidence that the NIDA CD4 count affects CD4 recovery and long-term clinical recovery in people on ART, but not impacting on ATI study, which is supposed to be a brief of treatment interruption with ART introduction. Again, a lot of these recommendations, remember, are also dependent on the idea that if there is less restrictive recommendations, that there is going to be more conservative monitoring, and that will take care of people being put on antiretroviral as soon as it is needed. But we can have more discussion during the Q&A.
Thank you. Thank you, Doctor. Wonderful questions. I think we're going to have quite a busy moderated session on this in just a little bit.